everyone. Good morning, good afternoon, good evening, and welcome to another NDD live training session. Today we are going to be looking at the DLCO test. The DLCO test can be performed both on the EasyOne Pro and the EasyOne Pro Lab. And so that is going to be our focus today, is to talk through this DLCO test. And I'm going to go ahead and get my presentation started, and we will get rolling. Just a second here. All right, sorry, I had to swap presenters really quick, and now you guys should see my screen for the live training with the EasyOne Pro. All right. So what are we going to learn today in this DLCO training? So first of all, we're going to start talking about how to set up the device for DLCO. What are the differences between how we set up the device for spirometry versus DLCO, or if you have a Pro Lab, then also for multiple breath washout. How are we going to set this up for DLCO? Second, we're going to talk about how to coach a patient through a successful DLCO maneuver. We know how important those coaching messages can be to make sure that we are getting the best effort out of our patients. So we're going to talk a lot about that today as well. We're going to learn common test errors, some of the common mistakes that we hear, our customer support hears when people call in, and try to help you guys avoid those with your patient. And then again, just encouraging that good test effort from your patients. And then at the end, we will reserve the last 10 minutes of the presentation for just an open Q&A with me. And again, my name is Jamie Burgess, and I am a registered respiratory therapist. I serve as the Global Research and Training Director here at NDD, and I'm just excited to be able to add another option into our live training library. So if you do have questions at any point during the presentation, there's a couple of different options of how to ask those. And again, we will address those questions that last 10 minutes of the webinar, but feel free at any time during the presentation, if you have a question, to go ahead and either use the chat feature or the question bar on your GoToWebinar toolbar. If we happen to not be able to get to your question in the time allotted, I do get a printout of all of the different questions and chats that were given during the presentation. So I can always follow up with you after the presentation as well. All right, so we're going to go ahead and get started. With the DLCO device, doing DLCO on the Pro or Pro Lab, I always say when I train virtually, there's always a little bit of movie magic involved, because as you can see, just with the webcam on the screen, sometimes there's a pretty heavy glare. So we're going to kind of be switching back and forth to being on the device, showing you how everything goes together, where all of our cables and tubes connect, and then also seeing a representation of the test shared through the computer as well. So a little bit of switching back and forth today, but hopefully you will have a much better understanding of the DLCO test on the Pro or Pro Lab once we are finished. All right, so starting with some basics. What is DLCO? And by definition, it's the diffusing capacity for carbon monoxide in the lungs. So this is a measure for gas exchange. We always say that, you know, spirometry is measuring how well we are moving that air in and out of our lungs. DLCO is that next step further, when we know that the patient can move air in and out, but then exactly how well is their lungs circulating that oxygen throughout their body? How well is it able to use the oxygen coming in and out? So it measures the capacity of the lungs to take up oxygen and distribute it through the rest of the body. In some areas of the world, this test is also called the TLCO test. So if you've heard that verbiage, we're talking about the same test. All right, I always say this is kind of the biology course section of the DLCO training, but let's just talk a little bit first about gas exchange. So we know during inspiration, or when we take our deep breath in, we bring air in through our nose and our mouth, and it makes its way down our trachea or our windpipe. Eventually, it makes its way down into the alveolar space, those tiny air sacs in the bottoms of our lungs. So the trachea branches into the bronchi, which branches into the bronchioles. The air must travel 18 to 24 generations of branching within the lungs before it gets to that alveolar space where the gas exchange actually takes place. So when we look at the gas exchange, we know that the alveoli are the ones who do that work in the lungs. The gas exchange mostly happens actually by passive diffusion between the alveolar space into the bloodstream. We know that red blood cells are the carriers for that oxygen, and that CO2 diffuses from the bloodstream as waste back into the lungs to be disposed of. So here's kind of a really close-up picture of a very, very zoomed in alveoli. So we know that, again, that oxygen is transported to the organs and the rest of our body by those red blood cells. We then know the organs use up the oxygen and leave the CO2 as waste for us then to dispose by exhaling at the end of our respiratory cycle. The CO2 binds to the red blood cells, it's transported back to the lungs, and then kicked back out as the second part of gas exchange. So all of that biology to say, why do we want to measure DLCO? Like I mentioned earlier, we really do look at spirometry as how well does the patient move air in and out of their lungs. And then DLCO shows us a much deeper picture of, now that that air is inside of the lungs, how well is the body able to use that oxygen that is brought in. So DLCO results, together with spirometry, other examinations, patient symptoms, patient history, all of these things together will reach a diagnosis of respiratory health. DLCO can also assist in identifying the nature, classifying the severity, and monitoring progression of a wide range of diseases as a whole. So some examples, why do we measure DLCO? We can use it to assess and to monitor the severity or the progression of a pulmonary disease. We can confirm or exclude respiratory diseases. So like I said, we can bring air in and out, but sometimes it isn't the lungs' fault that that blood is not going where it needs to go. Sometimes it's a cardiac issue, and DLCO is something that can really narrow our focus in on where this problem or where this patient's problem may lie. We can also use DLCO to assess anesthetic risk prior to surgery, or to monitor improvement to those on a treatment plan. So someone has been diagnosed with a lung disorder, they're now taking medication. We can use spirometry and DLCO then to trend how well that patient is progressing on their treatment plan. Another example that we have heard so much of the last few years is using DLCO as a recovery marker in COVID patients. So using DLCO helps keep track of those patients' pulmonary health long after they're discharged from the hospitals or the ICU. It's also a really sensitive marker for that potential long-term management of COVID patients. We actually have a white paper on our website that talks a lot about this, how even in normal spirometry, people that are still symptomatic, maybe they never even went to the hospital, sometimes will still have an abnormal DLCO. Because as we know, COVID at its core is a vasculature disease or a vasculature affecting virus. So DLCO has also come to the forefront in that long COVID treatment and monitoring movement. All right, this question always seems to come up when I go in to train people on how to perform DLCO, and that is, why are we using carbon monoxide for this measurement? We always hear carbon monoxide and our brains go to carbon monoxide is bad. We shouldn't be breathing that in. It's always the negative connotation, obviously, that goes along with carbon monoxide. And the reason we use it, though, is really simple. Carbon monoxide has a much higher affinity to those hemoglobins in the red blood cells than oxygen does. So this test can be performed much, much more quickly than any other gas that we could use. Its affinity or its attraction to those red blood cells is 200 to 250 times higher than oxygen. So being able to see this gas transfer in a much quicker modality is why we use carbon monoxide for this. I always tell people, you know, this is obviously a safe test. There are really no contraindications to perform DLCO tests, not even for pregnant women. The amount of carbon monoxide, you guys will see in a later slide, it is such a small percentage of our DLCO gas mixture. You probably get more carbon monoxide from sitting in your afternoon traffic. So if you ever have patients that do have concerns about hearing the words carbon monoxide, you can always tell them, the reason we do it is because it's just what works best for this test. And it is in the concentration that you are receiving, it is completely safe for you to do within the DLCO test. All right. So we've talked about why it's important. We've talked a little bit about the physiology of how we get a DLCO, but what parameters are we actually looking for in a DLCO test? What are some of those key words, different parameters that physicians will want to see during a DLCO test? And of course, the first would be the DLCO measurement itself. So that diffusion capacity or the transfer factor for the lung for CO. This is how well that CO is being transferred to the bloodstream. The next is the VA, or the alveolar volume. So this is the surface area in the lungs that is actually available for gas exchange. We know that there's some areas in the lungs, obviously a lot of real estate in there, that is not involved in gas exchange. But, if we were to stretch those alveoli out, I've heard many different illustrations where they would cover a tennis court, or they would cover, a very large amount of, we have a lot of area crammed into those little air sacs, those alveoli, that is available for gas exchange. The next parameter sometimes is a little bit surprising for people, but you can get a single breath TLC, or a total lung capacity, during the DLCO maneuver. And this is something that is becoming very, very popular. There's lots of different research being poured into this, different methods for how best to obtain that total lung capacity during the DLCO test. But this is something that can be added to your reports in your EasyOne Pro or Pro Lab device if you're wanting to get an idea of that patient's TLC from this test. Next would be the VD, or the anatomical dead space. So most of us have about 150 milliliters of air in our lungs, or that is just not used for ventilation, gas exchange, at all. So this can be the volume of air between our nose all the way down through the terminal bronchioles. So any space in our lung that is moving air but not actually involved in gas exchange. The last thing is the KCO. This is the ratio between that DLCO and the VA. And this really does define the diffusion capacity per alveolar unit volume. And it's a really good index that people use to actually look at that alveolar transfer. Out of all the surface area that we have, how well is that diffusing air for us? Right? And it also does help distinguish between some of our lung diseases as well. All right, looking back at that testing gas. Testing gases vary from company to company, but this is a really good kind of roadmap of what your DLCO gas should look like. So we have that 0.3% of carbon monoxide. We have 18 to 25% oxygen. We have a tracer gas, and then we balance the mixture with nitrogen. So the tracer gas is used to determine that VA, that alveolar volume, through dilution. In general, the tracer gases should be relatively insoluble to lung tissue, chemically and biologically inert, and they should have a similar properties to CO2. Common tracer gases that you will see being used by pulmonary function companies are helium or methane, and your EasyOne Pro or Pro Lab device will need a helium mixture in order to work correctly for the DLCO test. All right. As we move more into the specifics of the patient test on either the Pro or the Pro Lab device, patient information and positioning, what do we need to know about this patient and how do we need to prepare them for the test? We will always perform a baseline spirometry on the Pro or Pro Lab device prior to performing DLCO. That is really important for a lot of reasons that we will get into later. But the patient's information, such as their age, their weight, their birth, sex, their height, everything remains the same. So all of the information that you have entered into the device to perform spirometry will carry over into the DLCO test. The same goes for patient positioning. Everything that you would apply for rules for spirometry, as far as patient positioning, is also going to apply to DLCO. So we want to make sure that the patients are sitting upright with both feet flat on the floor. Any tight-fitting clothing should be loosened. Clothing we can or cannot see. Well-fitted dentures should be left in place, and maintaining that good posture with their chin off of their chest through the entire test. So again, all of the rules for this really do apply from spirometry straight over into the DLCO test. All right, this is just kind of a a close-up look of what our DLCO graphic can look like. And we're actually going to walk through each part of the test individually and go through what is important and what are those milestones to complete a test. I think that actually performing a DLCO test is hands and feet easier for the patient than performing spirometry. We know that spirometry can be very, very difficult for patients, especially sick patients, to be able to perform that forced maneuver, that really unnatural pattern of breathing that we have to elicit out of our patients for spirometry. It's a little bit different in DLCO. If you are familiar with the SVC test or the slow vital capacity test, a DLCO is very similar to that maneuver with the addition of a breath hold at the end. So looking at the different parts of the test, there are really 5 different parts to a DLCO test. The first one is tidal breathing. We want the patient to get comfortable with the setup of the device. You'll see in a minute, it's a little bit larger than a traditional spirometry handle. We want to make sure that they're comfortable with it in their hand, they have a good tight seal around the mouthpiece, and that there are no leaks around the mouth, and that the patient is only breathing through the mouthpiece because we have nose clips in place. After a few breaths on the device, we're going to have the patient do a maximal exhalation. So we are going to have them breathe out all of their air. This should be an unforced exhalation all the way down to their residual volume, or that point of expiratory plateau where no more air is coming out of their lungs. For some patients, especially with obstructive disorders, COPD, asthma, that exhalation might take them a little more time to get all the way down to that baseline, since we're doing this in a relaxed form and not a forced maneuver. We want to make sure that that exhalation time is no longer than 12 seconds. If it goes longer than 12 seconds, we do have the option to manually start the maneuver on the Pro and Pro Lab devices. As soon as we have hit that bottom of the lung, that residual volume, no more air coming out of the patient's lung, we want to instruct the patient to perform a maximal inhalation. So take the biggest, deepest breath in that they can. We want that to be a rapid inhalation. On number 3 here on the chart, you can see that that line is almost straight up and down. With this inhalation, there is something very, very important that we need to take note of, and you can see it in my picture here, and that is a horizontal dotted line. In order for the test to be an acceptable test, that inspiratory volume, that biggest breath in that the patient takes, needs to be at least 90% of the vital capacity that that patient just established in spirometry. So they have to meet or exceed that dotted line for it to be an acceptable test. We don't want the inspiratory time to be more than 4 seconds long. So if your patient is not hitting that dotted line, we want to encourage them to keep breathing in and filling their lungs until they have met that prerequisite of 90% of the vital capacity. And again, your patient's already done it. This is their vital capacity from spirometry that's already been established. So we know they can take that big of a breath. Sometimes it just feels a little bit different on the DLCO mouthpiece. All right, and during that maximal inhalation, that is when the test gas is being inhaled. Number 4 is the breath hold. So the breath hold must be plus or minus 2 seconds on 10 seconds. So you will actually see the countdown on our screen. During the breath holds, we want to make sure that that line is very, very straight. We don't want them to try to inhale through their nose or around the mouthpiece. We also don't really want them to swallow or do anything other than just hold their breath for that countdown. We want to make sure that we have a really, really good breath hold before step 5, which is we will have them relax and just fully exhale. Again, this is smooth, unforced, without hesitation, meaning as soon as the countdown hits 0, the patient can relax and fully exhale. So I always say this sounds like so many steps, so many different steps for the patient. To tidal breathe, fully breathe out, fully breathe in, hold your breath, and then relax and breathe out at the end of the test. And it really is, makes a lot more sense when you do see it in sequence with the test. So while there are several steps to take into account, don't be overwhelmed. Our software also does coach you through every single step of the maneuver. All right, so now it's time to test. We've kind of talked about what the test screen looks like, the different steps of the test. So now we really actually need to get set up to do a DLCO test. So I'm going to go ahead and switch my screen. All right. And we're going to talk a little bit about what needs to happen on your ProLab device to get ready for the DLCO test. So I have my Pro behind me. Again, with the webcam, it's always hard to see the screen, but right now we're just going to be focusing on the parts and pieces of the Pro itself. So I have my gas tank connected in the back, and you'll see that this gas tube is connected to my gas regulator. On the gas regulator, we really only need to set the flow rate on that twice, and it should be between the 5 and 6 bar for your PSI. We want to make sure that we have a full tank, which there will be one dial. I know that everyone's regulators, depending on where you're watching in the world, are a little bit different, and so I didn't want to spend a ton of time focusing on what a US regulator looks like, because that might not be what you are looking at. But one dial in the US on the right-hand side is going to actually show us the tank volume, how much gas is left in the tank. And then again, in the US, on the left-hand side is going to be the flow rate. How quickly is the gas coming out of the tank? And that will be something that you manually adjust only when you're changing out your tanks or starting for the first time. And again, we want that needle to be in that 5 to 6 bar range. All right, with our gas tubes that are connected to the regulator, while we can tighten those really, really well with our hands, we want to make sure, since this is a completely closed system for this test, that we don't have any leaks. If you are during the 5-point check, which we'll talk about here in a minute, if you're getting an error message that you're having a leak, or if you can hear a leak happening between your gas tank and your device, I carry with me everywhere, no matter what, a wrench, because you can come in and manually tighten those pieces just to ensure that you don't have any leaks between the gas tank and the device itself. So always make sure that you give those an extra tighten with a wrench before you start testing. All right. On the side of your device, you're going to see that there are 2 connections. One connection for your spirometry sensor, and then the other is that gas tubing. So you'll note when we do spirometry, we actually only need the spirometry handle portion of the device. But when we're ready for DLCO, we'll need to actually put the motor block onto our handheld sensor. So again, it's a little bit difficult to see here, but I do have mine colored in with a Sharpie marker. So you'll see that there are 2 arrows stamped onto either side of your handle. All right, to take the motor block off, you'll push the silver button, slide the motor block back to where the arrows are perfectly lined up, and then just simply lift the motor block away. We want to make sure that we're lining up the arrows and lifting straight off so that we're not bending any internal pins in either the hand sensor or the motor block. All right, and the same way to put it on, we would line those arrows up, one on top of the other, keeping the handle stationary, sliding that DLCO block forward. All right, when we're ready for our DLCO test, we assume that we have, again, already completed spirometry. So our spirometry handle should already have a Spirep mouthpiece inserted. And just like on spirometry, we want to make sure that the arrows on the mouthpiece are lining up with the arrows on the spirometer, and then we're ready to test. Once spirometry has been completed and we're ready for that DLCO test, there's one more piece, one more disposable piece that we need to have, and that's we need to make sure that we have the DLCO barriette. The DLCO barriette is what's going to protect all of your patient tubing back to your device from any contaminants from your patient. All right, so the DLCO barriette is a round filter, and it actually gets placed on the motor block prior to testing. All right. You'll notice on the one-way valve on your motor block, there are some silver arrows, and then you'll also notice that your DLCO barriette has arrows on it as well. And all you need to do is just press that DLCO barriette down to where it is snug and nestled in arrow to arrow. All right. Once your DLCO barriette is in place, you would then attach the motor block to the hand sensor, just how I showed you before. So we're gonna line up those 2 arrows, and then we're gonna slide the motor block forward until we hear it click. I did want to point out that I know several of our customers, we do have an inline filter solution for the Pro in the Pro Lab. And this is a different solution than if you are using, let's say, the EasyOne PC or the EasyOne Air. And the difference is we can't have our EasyOne filter on the back of this device because that would impede the movement of the motor block during the DLCO test. So for the EasyOne Pro, if you are using the filter kits, your setup is going to look almost the same, but you'll be using the filtered mouthpiece on the front of your device. All right. Go ahead and swap back over to a regular Spirette here. All right, so we're all ready to test. So we have our devices set up, our gas is turned on, and the flow rate is set to an appropriate flow level, that 5-6 bar. Our barriette is in place. We've already performed spirometry, and then we're ready to start the DLCO test. Just so that you guys can see what that looks like, I'm going to just do one quick FVC for you guys on my software, just so that you can see really quickly what that test sequence looks like. So I'm going to go ahead and swap my screen over to our software. All right. All right. So again, I already have myself selected as a patient, but if you need to add a patient to your list on your Pro or Pro Lab device, you would click on Patients, click on New, and then enter the patient information. The items that are starred on the first page are absolutely required for our predicted value sets to be able to determine what is normal for your patient. All of the other fields are optional fields. So are they a smoker? Have they been diagnosed with asthma, COPD? Who referred this person over for the test? Do they live at a residence of high altitude? Or any other comments you might have on this patient account. All right. Once the patient is in the system, you'll see that their name is highlighted on the patient screen, and you'll see that their name is also now showing up in the lower left corner of your Pro and Pro Lab screen. All right. Sorry about that. It stopped sharing for some reason there for just a second, but we are, I think we're back on sharing now. So sorry. There we go. Okay, just confirming. So once our patient is in the system, we'll be ready to test. And again, we always want to make sure that we have spirometry on the Pro or Pro Lab prior to doing DLCO. So I am just going to, again, very quickly do an FVC trial for you guys so that you can see what that looks like. And if you have FVC specific questions, we have lots of other live training sessions that are looking at the FVC test. All right, I'm blocking the Spirette until prompted to blast out. All right, when it tells me to start the test, for FVC, I'm gonna have the patient make a good tight seal, big deep breath in, blast it out as hard, as fast as they can until the device tells us to stop. Awesome. And again, I'm not going to spend a ton of time in FVC. We know, I assume that a lot of us know the rules of spirometry. We're going to do a minimum of 3 acceptable, reproducible trials before we would move on. We would want to make sure that we have that session complete great job, meaning that our spirometry session is acceptable, reproducible. We have confidence in that patient effort and the results before we would move on to DLCO. So from the results screen here on your spirometry test, whichever spirometry you're doing, if you're doing FBL, FBC, from this screen, we will actually just click on test to take us back out into the test menu. All right, I have my computer software set up right now to look like a pro lab device, meaning I also have multiple breath washout available. So if you're following along and you have a pro device, you will not have that multiple breath washout test, but otherwise this screen should look very similar to what you see as a pro user. When it's time to do DLCO, the device is going to run through what is called its 5-point check. That is checking the setup of the device, it's checking the environmental factors of your room, it's checking for leaks within the system, and it's going to do that between every single DLCO trial. So we just have to anticipate once we hit that DLCO button, there's going to be about 30 seconds before we're actually ready to hand the mouthpiece over to the patient. And I normally do use that time to explain to them exactly how to perform the test. And again, I always tell them the full test when we get started, but always remind them that I am going to give them step-by-step instructions throughout the exam. So again, we're going to start with tidal breathing, normal breathing. After 3 or 4 breaths, we're going to instruct the patient to fully exhale or to blow out all of their air. At that point, us as the practitioners, we have one more step that we have to remember, and that is to hit the activate button. We can hit the activate button at any point during that exhalation, but that is just telling the device to get ready and to watch for that expiratory plateau so that the device knows when to push the gas. So the patient is fully exhaling, we're going to hit that activate button. And as soon as the device prompts us, we're going to hear the gas release and we're going to have the patient take a big, big, big deep breath in up and over that vital capacity dotted line. At that point, the patient's going to hold their breath. And then once that countdown hits 0, again, they're just going to relax and fully exhale. All right, again, because of movie magic, we are going to actually go through a recording of the DLCO test so that I'm able to talk with you through each step. The rules for DLCO are a little bit different from spirometry, which we know is we have to have a minimum of 3 acceptable reproducible trials. With DLCO, we need 2 acceptable reproducible trial, and we do not want to exceed 5 tests. Between each trial, there will be a countdown on your screen, a 4-minute countdown, but we do want to wait that full time between tests just to give their body enough time to naturally reset, essentially, to expel all of that CO from the gas mixture and to be ready to test again. So I'm going to go ahead and click on the DLCO button. And again, this is a recording, so we can talk through it. I just confirmed the environmental settings, and now the device is going through the 5-point check. You'll see that there was a quick reminder to make sure that you had the DLCO barrier in place. And at this point, we are going to just let that 5-point check cycle until it tells us it's ready to start the test. All right, just still waiting on the 5-point check, and it's given us the instruction to tidal breathe. So we're going to have the patient just do some normal breaths. Again, 3 or 4 breaths just to get the patient comfortable breathing on the mouthpiece. I'm going to instruct the patient on this next breath. I want you to fully exhale, blow out all your air, and I hit activate. They're blowing out all their air, blow out, blow out, blow out. Big deep breath in, up and over the dotted line. Hold your breath. 5, 4, 3, 2, keeping your mouth on the mouthpiece. Now we're going to fully exhale, nice and relaxed. And that DLCO trial is going to end automatically for us and send us over to this screen with our results. So one thing to note, and I will actually show you guys the screen grab again here that I showed you from the PowerPoint presentation earlier. The test screen in our video, the results screen in our video looks a little bit different than what the test screen looks like right now on the Pro or Pro Lab device. And that is just because my recording is a little bit old. It was prior to the implementation of the 2017 DLCO standard. So you'll notice a few differences on the video versus the screen you're seeing right now. So you'll see that that session quality grade is in the upper right-hand corner. So that is how repeatable is our test, looking at that repeatability between trials. We want to make sure that we have A letter grades before proceeding. Down below, you'll also see on that feedback bar that is green, it's telling me that this was a grade A trial. And in this example, because I've done 2 trials, the session is complete. You can see underneath that, I have all of the different parameters selected with my real-time values to the right-hand side of that, with trial 1, which is a letter A grade, and trial 2, which is a letter A grade. So there's a few differences from what you see on the video and what the actual screen is showing you guys. 2 more things to point out on the screen before we watch another trial, and that is over here on the right-hand side, you'll see that there's an area to leave a comment. So this is any comment that you might need to relay to whoever is reading your tests at the end of the day, whether it is patient tolerated well or after 5 trials, this practitioner elected to end the test due to patient exhaustion, or patient didn't understand the test instructions, or whatever you would need to convey, you can leave in that comment box. Right below that is the second thing I want to point out that says adjustment. So if your physician has the DLCO adjusted selected, we want to adjust for the patient's actual hemoglobin, not just what it should be for their patient demographic. For myself, a 38-year-old female, we want to know, we want to have their DLCO exactly correlate with their hemoglobin. We can go into that, and if we have an ABG or a CBC within the last 30 days, we can put those real-time values in, have the DLCO adjusted parameters showing to be able to make that correction. So just a couple of things I wanted to point out on the test screen before we go back and watch another trial. All right, so you can see here in the middle of the screen that 4-minute countdown has started. And I'm going to go ahead and push play on this video. The video does speed up here in just a moment to get through this 4-minute wait. But again, I do encourage you always to go ahead and wait the full time between trials, just to allow the patient to get back to that normal breathing pattern and normal gas levels within their lungs before repeating. All right, so once the countdown hits 0, you can hit to start the test again. It will go through the 5-point check a second time, checking the environmental factors, checking for leaks, checking the gas composition, and making sure the device is ready to test accurately. All right, as soon as the 5-point check is over, it's going to give us the instruction to begin tidal breathing. So again, I'm going to have my patient take 3 or 4 just normal breaths to get used to breathing on the mouthpiece. And once I give the instruction for them to, on this next breath, fully exhale, I hit activate. They're still blowing out, they're still blowing out, they're still blowing out, they're still blowing out. Big, big, deep breath in, up and over the dotted line. Hold your breath. 4, 3, 2, 1. Mouth on the mouthpiece, fully exhale to finish the trial. All right, again, that trial is going to end for you, and it is going to send you over to the results screen. However, again, this screen is the screen on the video is a little bit older, so I'm going to pop back over to this screen just so that you guys can see what it looks like now with the session quality grades and the individual trial grades at the bottom of the screen as well. All right. Once we have our test completed, we have a couple of different options here. If you are hooked directly to a printer, you have your preferred test type selected, you can go ahead and just hit that print button to get your print out from your Pro device. Now, the Pro and Pro Lab device do not have a Wi-Fi feature. So getting the test off of the device, you will either need to directly print from the device or transfer the data either with an Ethernet cable if you have a direct EMR connection, or via a flash drive, which I know is how so many of you guys do that, to export those tests for the day to a flash drive at the end of the day, then upload those into your onto your computers in your clinic. All right, so if I were to hit that report button, there are a couple of different options on how we can look at the DLCO test. And I actually did a DLCO test on myself this morning on my Pro so that I could show you guys. You'll see it is today. This is what the standalone DLCO report looks like coming off of the Pro or the Pro Lab. You'll see all of the patient information up top. You'll see the DLCO, the test date. You'll see the predicted value that I have selected below that. and then all of my different parameters, with that best parameter being highlighted in that far left column. Below that, you will see a readout of your session quality grade, your Z-score graph, and then you'll actually see those tracing scores on the DLCO standalone report. However, I know a lot of you also want to see your spirometry and your DLCO, everything together. So the option, we have two different options for that. We have the summary and the summary 2-page report. And here is the summary 2-page report. Again, it's going to have all the patient information up top. Below that, it's going to have my spirometry. And then below that, it is going to have the DLCO. If you are looking at this, don't be concerned. I am asthmatic, but you'll see that I have a session quality grade of an A, both for FEV1 and FVC and spirometry. I have a session quality of a good test. That result is off of 2 grade A trials for DLCO. So I have really good confidence in this test that it is a good patient effort and that these results are reliable. On the on the summary 2-page report, depending on what interpretation standard you have selected, you can also see a diagnostic tree. Again, this is completely accurate for me based on the Gold-Hardy interpretation. I go right down the tree and land right on that asthma tile, which again, for me is accurate. We do have the capability to take these graphics off, but again, this is also dependent on what interpretation standard you have selected for both for your spirometry, for the system interpretation for spirometry and DLCO. All right, on the summary 2-page report, if you have left any comments throughout the test, they will appear here. And then of course, there is a place for a physician signature. All right, hopping back over to the slides before we wrap up and move into questions. And that is, we've talked a lot about an acceptable and a reproducible DLCO test. Well, what exactly does that mean? What makes it a good test? We talked about one big thing, and that was getting up and over that vital capacity line. We know that that is make or break for a DLCO test. But another thing that we talked about is we want that volume time graph to have a smooth, sharp rise, no more than 4 seconds to fully inhale up and above that vital capacity line. We also talked about we want that graph to stay stable during the breath hold. We don't want it to be wiggling around. We don't want them to be taking extra breaths through their nose, swallowing, leaking. We want that to be a nice, solid breath hold. And on the other side, we want them to have a sharp and smooth exhalation. Again, this doesn't need to be forced, but we do want them to relax and just fully empty their lungs. All right, there's a couple of different examples here of leaks on the right-hand side of the screen, but we talked about how that gas concentration should be sharp and have a very sharp rise when the test gas is introduced. That test gas should stay stable through the breath hold, and then again at the end, it should have a smooth decline when that patient fully exhales. We've talked about it a million times, but I put it in about 4 different slides to make sure we all remembered. We absolutely have to get above that vital capacity goal line that is marked with the dotted line. We must make sure we get above that. Our breath hold is 10 seconds plus or minus 2. No leaks, no swallowing during the maneuver, and that sample must be collected within 4 seconds of the exhalation. So as soon as that countdown hits 0, we want to go ahead and instruct the patient to fully exhale. Repeatability. So not only was the session a good quality, we met all of our criteria, but how close does trial 1 look to trial 2 in terms of how well we can rely on the accuracy of these results? So at least 2 acceptable DLCO are recommended, and they need to be within 2 mLs per minute per mmHg. All right, so that's a really, really tight window. This is not something that you guys have to manually calculate on your own. The session quality grade is going to be assigned to tell you it was a good test based on those individual trial grades. Again, we do want to wait 4 minutes between trials to allow them to kind of reset to baseline. If patients with severe airflow obstruction, you might want to give them a few extra minutes just to make sure that they have fully kind of returned to normal breathing before doing a second trial. All right. We have gone through all of the details of what we're going to go through today of a DLCO test. So I do want to take this last 10 minutes or so to open it up for questions. Bianca is on the call with us today, and she's going to be doing reading our questions to us. I'm going to go ahead and stop sharing my screen. I'm going to set my mouthpieces over behind me here. And then we're going to go ahead and take a look at some of the questions that might have come up. And there's still time for questions. If you have anything that you want to go through, be sure to type it into the questions or the chat bar now so that Bianca can see it.
Awesome. Thank you so much, Jamie. So we have quite a few questions popping in here, so I'll just go ahead and get started. So I have a question here regarding the DLCO maneuver itself. What to do if the patient can't inhale fast enough before that countdown begins, that breath hold?
It's hard. Honestly, it's coaching. I mean, I wish that I had a magic cure for that. But I mean, if you ever listen to me coach DLCO, as soon as that gas injects, I'm telling them, bigger breath, bigger breath, bigger breath, bigger breath, trying to get them to take the biggest, deepest, fastest breath possible right now. We know that it's, you know, just because some people's conditions, it's going to take them a little bit longer to get up to that VC. But just honestly, it's coaching. Making sure that they understand we want that line when you breathe in to be as straight as possible, up and over the dotted line. If they don't make it in the first second or two, I'm telling them bigger breath, bigger breath, bigger breath until that breath hold kicks in. Remember, we do have a little bit of give with the plus or minus 2 seconds off of that 10, but we really do want to try to, via our coaching, encourage them to make that big sharp inhale within that 4-second time window.
All right, great, awesome. Oh my goodness, they're coming in. So I have another one here. At the end of the test, sometimes the system prompts a very long final exhale. What might be the cause of this?
Sometimes, so there can be a couple of different things. Sometimes it's just waiting for the patient to kind of get back down to that baseline. So kind of where the bottom of their tidal breathing is, if that makes sense. If the patient is taking a while to get there, sometimes just having them take a quick breath in will go ahead and automatically end the trial, because kind of as long as they're breathing out, that it's going to keep recording data. Another thing to double check too is in the settings of the device, make sure that you don't have the manual stop checked. Or if you would like to always manually stop the maneuver, you can have that on. But there is an option in the utilities configuration test section under DLCO where you can have it to where you have to manually stop the maneuver. And so that's one thing to double check too. Just make sure that you, if you don't want it, that you have that manual stop turned off. But again, sometimes if it's taking a while for the device to kick over, have the patient take a small breath in, and that will go ahead and cycle the trial off and take you to the results page.
All right, perfect. Thank you. Another question here regarding hemoglobin. If hemoglobin is not immediately available, is it possible to add it in later on the laptop?
Yes.
Or does it need to be placed on the device?
Yes. So yes to both. So again, if you do not have the CBC ABG available, your doctor is wanting to look at DLCO adjusted, you can come back in at any point. So on a test that you have done previous, let me just show you really, really quickly here. I'm going to go ahead and let me see. I'm going to go into one of my test patients here. So if I go back into the history of my patient, so whether that's still on the Pro device or whether I've uploaded the test into EasyOne Connect and I'm manipulating it there, I can go back in and view these past tests, and I can go in, instead of hitting report, I would hit view. And then I could come in and make that adjustment before I generate the report, or could make that adjustment and regenerate the report from either the device or within EasyOne Connect. So just going back into the patient's history and going to results going into view versus report, and you can make that adjustment and refigure a report at any time.
Awesome, thanks, Jimmy. We had quite a few questions on that, so that I think that answered a few questions here regarding that. Let's see here. I have somebody here asking, do you recommend a DLCO with all pre and post spirometry?
Oh, all right, that's a hard one. So the respiratory therapist and myself will say, yes, I want that information every time. However, depending on your patient, sometimes if we have a patient who is restrictive or a patient who maybe has something other than an obstructive disease, maybe spirometry is enough, or maybe, it's spirometry. And then for restrictive people, you need to jump to lung volumes, whether that is single breath with DLCO, multiple breath washout pleth. When I always recommend it is especially in our obstructive patients, because obstructive patients, as we know, a lot of times can have that vasculature component involved. So we know that spirometry can tell us obstructive restriction. It can't tell us COPD, asthma, fibrosis. It can't give us that diagnosis, to where DLCO is just that next step of the puzzle. So again, as a respiratory therapist, my answer is absolutely. I want to know my DLCO on anybody that I am testing for spirometry and their spirometry was abnormal. But I say that also with a little bit of an asterisk, like I mentioned earlier, DLCO sometimes is a more sensitive parameter to how a patient is feeling versus spirometry. In these COVID patients that had, they were not hospitalized, but they were still symptomatic at 90 days, normal spirometry found the impairment on DLCO. So again, the RT in me says, yes, do all the tests all the time. I know that that's not realistic for everyone, but especially if someone has abnormal spirometry, even if we can correct it with a bronchodilator and they're back to normal, I would want to see the next piece with how well are they actually diffusing that oxygen in their lungs. But again, that's not a right or a wrong answer. Again, the RT in me, I want all the information I can gather on this patient. So especially if I think my answer could always be, if their spirometry is abnormal, absolutely. But again, that's something that, is kind of different for every patient and every clinical situation. Yeah, that's kind of a long answer to a short question. But.
Good. No, that's great, Jamie. Thank you. A few more here. This is a good question regarding what's the easiest way to explain to the patient what DLCO does?
So this is going to sound so silly, but spirometry, air goes in and out. DLCO, blood goes round and round. I know that sounds like the most preschool answer ever, but it really is. I tell my patients, spirometry, I need to see how well you can actually move the air in and out of your lungs. Is there a defect in the structure of your lungs? Are you filled up with mucus? Is the elasticity of your airways compromised because of smoking or COPD? Spirometry is how well we can move air in and out. DLCO is that next step, that now that we are moving air in and out, what is our body doing with it? How well is our body actually distributing that oxygen from our lungs to the rest of our body? And that is really what I tell patients. This is that second step. We've moved the air in and out, then we need to see blood goes round and round. As preschool as that answer sounds, that is really at its core what the explanation that I give to patients.
All right, that's great, Jamie. Good. So I have another one here. It's what happens if a spirometry test isn't done before DLCO?
So if a spirometry test is not done on the within the 24-hour period on the Pro or the Pro Lab device, you're going to get a pop-up window that says that you have not performed spirometry today. Do you want to go back and perform spirometry, or do you want to proceed? And at that point, the VC goal is not necessarily your patient's. It is still a goal that is set based off of, their patient demographics, their gender, their height, their ethnicity, their sex at birth. It's a good guess. The VC goal is a good guess at that point. But to really get an accurate picture of DLCO for your patient, you really do need to have the VC established in spirometry on the same day as the DLCO test. So it will allow you to test, but again, we are looking at an idea of what that patient's VC is versus their actual VC from spirometry.
All right, great. Awesome, Jamie. A few more questions here. So one is regarding on how young of patients can you do DLCO testing? So 7 years older?
Yeah, normally, I mean, again, a lot of the predicted values we don't have a ton of predicted values for kiddos that go all the way down. We have GLI 2017, which goes down, I believe, to 4, just like it does for spirometry. But we just don't have a ton of predicted values for those kiddos in DLCO. There are several that are older that are an option on our device. If a patient is mature enough and they understand how to do spirometry, you're going to be able to walk them through a DLCO, because honestly, it's an easier test patient instruction wise than spirometry is. But when DLCO is appropriate in children, there's a little bit of mixed media about that out there. Again, I mean, it's going to give us the same information on a child as it is an adult. Children are not quite as prone to vasculature issues as adults who also have respiratory impairments are, but we know adult, pediatric, whatever, sometimes those things go hand in hand. And so, I mean, I think it's something to discuss with your providers. If you are the provider, you know, maybe I can help you, like we can pull some different papers that are out there on DLCO in pediatrics. As far as understanding how to do the test, if they can do spirometry, they can do DLCO. But again, we just don't see it as common. There's not as much literature out there about it. There's not as many predicted value sets out there that are a pretty good representation of today's population. But there are lots of pediatricians, especially asthma, allergy, different ones, who want to see a DLCO on their kiddos. So I'd say the same kind of rule. If there's an abnormal spirometry and the patient you think could perform a DLCO, there's really not a reason not to.
All right, great. And I have one more question here, and I think it about wraps it up. But I have a question about if doing post spirometry, should the albuterol be taken before or after the DLCO test?
All right. So when I teach in sequence, I teach to do the post after DLCO. So the sequence would be pre-spirometry, give your bronchodilator, DLCO, then post spirometry, because we're waiting 4 minutes between trials. By the time your albuterol kicks in, you'll have completed the DLCO and then can do your post spirometry. I know that there are some, you know, I work a lot with research. Some people want to keep spirometry completely on its own, wait 15 minutes, post, and then if it's, you know, whatever the results of the post are, then proceed to DLCO. When I am teaching in the clinics, I mean, you guys don't have time. I mean, a lot of times to wait 15 minutes to where, you know, the albuterol takes about 15 minutes to kick in. That's about how long it's going to take us to go through everything else. I mean, and plus some time to go through DLCO. So again, the way I teach it is give your medicine, do your DLCO while your medicine is activating or kicking in rather, and then do your post spirometry last. But again, whatever your facilities policy and procedure is on of that, there's not a wrong answer. Just doing it that way does not affect your test results in any way, and it saves you a little bit of time when you're looking at it from a workflow perspective.
All right, good. So otherwise, Jamie, I think I just have a few questions regarding receiving the training, the recording after, and also some questions on certificates, which I think you covered at the beginning. But that, yeah, everybody should receive a copy of the live training, and it'll be accessible on our website and on our YouTube channel within 24 hours.
Yes, yeah, GoToWebinar sends it. I don't have any control over when they send it. Normally it's 24, right about that 24-hour mark from right now. You'll get that follow-up email from GoTo that has the recording in it. So yep, and then again, like Bianca said, we'll have it posted on the website so that you guys can go back and access it at any time. If you had questions that didn't get answered, I will look through all the questions. I'll see them. Or if you have any questions that pop up once we are offline, please feel free to reach out. I'm always happy to help, especially I love DLCO. I think it's a fantastic test. I love teaching it. So I'm happy to help anything that comes up after this webinar as well. Please feel free to reach out. And thank you guys so much again for joining us. Next month, we're actually going to be doing multiple breath washout is our focus for live training next month on the Pro Lab. So if you're a Pro Lab user, make sure you're watching out for that. Or if you're just somebody that is interested in possibly moving from spirometry and DLCO to adding that washout component, be sure to join us. And we just thank you guys so much again. Have a wonderful rest of your day, and we'll see you again in another live training session soon. All right, thank you. Have a great day.